Right, everyone. I think we'll make a start if that's okay. So you are very welcome to this meeting of the Health and Adult Social Services Standing Scrutiny Panel. This is a hybrid meeting. So we've got members in the room and some officers too, but we've also got some colleagues that are joining online. The meeting is also being live streamed on YouTube. Could I remind members and officers who are online just to be on mute and to raise the hand icon if you wish to speak? That would be great. So I understand at the moment that we have got Councillor Alexander and Simon Crawford from London North West Trust online. I'm also expecting Councillor Ty to join online as well. So in terms of item 1, which is apologies for absence, I've got apologies from Gulam Mataza. Have we got any other apologies from members? No. In terms of item 2, urgent matters, pleased to report there are no urgent matters for consideration on this evening's agenda, which brings us on to declarations of interest. So I'll get us going by declaring my interest as an employee of the Nursing and Midwifery Council. Councillor Conti, I'll come your way next.
I'm a GP in North West London.
Any other declarations of interest? No, in which case we will go on to item 4, which is matters to be considered in private. There are no matters to be considered in private as part of this evening's agenda, which takes us to item 5, which is the minutes of the previous meeting. Can I ask panel members if you're content that the minutes of the meeting held on the 10th of July are a true and accurate record? Agreed? Thank you very much. That then brings us on to the panel work programme, which has been tabled. So a couple of things that I just wanted to point out. The meeting in January has an item on mental health services, CAMS, and the North West London mental health strategy. It's quite a wide-ranging item, and we'd really like to determine the scope of that further. So if there are specific areas that panel members are interested in exploring as part of that item, feel free to speak up now, or you can contact me after the meeting. I should say that CAMS was covered in the Children's Scrutiny panel in March 2024, so it may be advisable for us not to revisit that so soon after that particular scrutiny item. But other areas that colleagues would like to dig beneath the surface of in terms of mental health, anything in particular that that's really driving this item being on the agenda? Councillor Conti.
I think it was last year we looked at like inpatient mental health, but we haven't looked at outpatient services. And I just wonder whether sort of patient experience and also sort of how sort of patients are sort of flowing through the system might be a useful thing to look at. And I don't know if Health Watch have done any sort of patient satisfaction on mental health service that we could look at as part of that.
David, I'll bring you in if that's all right.
So, Councillor Conti, we are actually, as a part of our work programme at Health Watch, we're doing a journey through the mental health system piece of work, where so far we have been in mental health wards to get their patient experience. That piece of work was a separately commissioned piece of work by the Trust that used to be held by Health Watch Hammersmith and Fulham, but since Hammersmith and Fulham has a change in provider, so that piece of work is now hosted by Health Watch Ealing, so we're working on that. We're also visiting mental health hostels this year and as a part of this project, and we're also going to be looking into outpatient services. So if you'd like to have a meeting with me at some point to discuss that further, I'm completely open to do so.
Well, let's pick that up actually, because there might be the potential to look at, I'm thinking particularly in the visit space, something that we could do that broadens the sort of scope of our scrutiny related work. So yeah, I think that gives us a really good steer. Anything else in the mental health space that colleagues would like to cover? Perhaps dwell on it and then come back to me via email if anything occurs. Similarly, the meeting in March, we have a scheduled item on the role of the voluntary sector within health services. It'd be really good to consider some focus areas for this particular item. So again, throwing the question open to colleagues. Anna Bryden, our Director of Public Health, who's online, sort of said that the panel may wish to explore some of the following aspects. So how the voluntary sector supports the delivery of health services, some of this intentional through grants for local community and voluntary organisations, whereas some of this will be as the result of kind of open procurements. How performance is monitored, how the community and voluntary sector capacity building is planned, especially through the Council's Connected Communities vision, and how community and voluntary sector organisations will be linked into neighbourhood health planning moving forward. So are there any other areas that colleagues would like to consider, or are you kind of content with that scope of the item? I'm taking the silence and a few nods as consent, so we'll proceed on that basis. In terms, we might need to just think about the scope of that overall kind of work package in terms of, because that's quite a lot to cover in one meeting. But if the panel are happy, we'll take that away, myself and Councillor Steed, just to think about that in terms of our planning session. And then I was just going to add the other thing that has been added to the list of potential scrutiny items is the falls prevention and embedding the Ealing carers strategy in hospital practice engagement training and support for carers in acute setting. They've both been added as items, and thank you, Gule, for your suggestions around that. Anything else anybody wants to say on the draft outline work programme? In which case, with the endorsement, oh, Gule, sorry.
Can we just add community end of life palliative care somewhere?
Yes, I might catch you about that separately because it comes up in the context of the North West London JOSC. So there might be some overlap with that particular item, but let's pick that up separately, and we can definitely consider it for a future scrutiny meeting, no problem at all. Great, in which case we'll move on to item 7, bang on schedule at 7:10. We have an hour for this item. It's a big chunky piece of work that Neha, Vijay and colleagues are leading on changes to the health landscape more generally. So Neha and Vijay, I know you're going to outline the changing role of NHS integrated care boards and the new course for the NHS set up by the NHS 10-year plan. It's a systems-wide approach, so we've also got Simon Crawford, Deputy Chief Exec at London North West Trust, joining us online, and Dr. Christopher Hilton, Chief Operating Officer Local Services at West London NHS Trust, and our own Director of Adult Social Care and Public Health, Kerry Stevens. So what I'll do is I'll pass over to you, Neha, in the first instance. I know you've got a presentation to take us through. We'll go through that and then we'll invite questions from the panel afterwards, if that's okay.
Thank you very much. And I'm going to share my screen with the slides, if that is okay. Really keen that I'm able to explain to you what is happening in the context of all of the changes that are happening at a national level, at a regional level, but then how that would potentially impact Ealing. And I say potentially because some of the changes are still unknown at this stage. We're still waiting for some national guidance on a few things. So I'm just going to, I think that's big enough. If you'd like me to make it any bigger, I'm happy to try and do so, if that's okay. So I'm going to start with some of the national changes that are being planned. So some time ago, the government announced the plan to abolish NHS England. And in doing that, they were planning to bring DHSC and so the Department of Health and Social Care and NHS England together, as they felt there was some duplication between both of the functions. And that would help to reduce some of the staff and capacity and overlap and make some savings. But in the same announcement, they also announced a reduction to the Integrated Care Board's staffing by about 50% by April 2026. The diagram on the right-hand side of that, which is the triangle diagram, sort of describes what that future model would look like. In effect, the national DHSC, NHS England combined would try and merge and provide that national leadership and policy direction. The regional teams, so for us that would be London, would provide regional oversight and performance and manage the providers directly, the large acute providers in particular, and some of the larger providers directly, along with the ICBs, and provide that strategic, some of those strategic planning pieces. The integrated care boards would become a strategic commissioning function, really focused on improving population health outcomes, reducing inequalities and assuring high quality and efficient care. And then the providers at a more local level would work together to become a collective of organisations really providing that high quality care and working together to make it much more integrated. And this was set out in a model ICB blueprint document. As part of the changes to the regional teams, however, there was also the ask that some of the functions that the regional teams would then move to the integrated care boards as well. So we're still working through how that would work. So in effect, you're sort of redesigning, allocating responsibilities right to the front line. Let's move to the next slide. As an ICB and the Integrated Care Board, the ICB would take on the function as a strategic commissioner, understand the local needs, use data, really find out, listen to local people through the provider landscape, and try and arrange and commission services that were much more strategically aligned to sort of doing once well across a larger landscape than trying to do everything at a smaller level, which in the past has been at borough level. And they would then commission that. They would set the strategy, commission that, and contract that of the local providers to then work out how to deliver that. The contract management of those things that the ICB would commission would stay with the ICB, but the performance management of the larger providers would move to the regional and national teams. In order to realise that vision, actually what needs to happen is some of the realignment of some of the responsibilities at a more local level. And I'm going to try and describe some of that. But before I do that, I'm going to just explain the cuts to the integrated care board that are planned. So for the integrated care board to take on some of the functions of a strategic commissioner, they would have to move some of the functions that they do directly for individual patients and direct individual patient commissioning, like continuing healthcare assessments possibly, or certain functions, down to the providers as a collective. At the moment, the Integrated Care Board also has borough-based teams within North West London who do a lot of the convening and bringing all the partners together to really work in a much more integrated way, understand each other and think through the solutions. The future landscape would be that the providers need to organise themselves to do that as a collective. That's health and care partners, which is why we're all standing here together. This ambition set by National was that the integrated care boards needed to reduce their running costs from what they are now to a standard £19 per head of population for that area. So they would have to have all of their costs meet that. So for North West London, we have a population of about 2.8 million GP registered patients, and £19 per head times that 2.8 million population is the pot of money that the ICB would have to use to have a staff and estates and those functions. It's not about what they commission. The commissioning budget is still stays the same. So what they're purchasing from providers still stays the same. This is about reducing the back office and head office staffing costs down to £19 per head of population. And very quickly, it became evident that as a North West London system, we are already a very large system, but to really make that £19 per head of population go further, they wanted to explore the opportunities of working with North Central London. And therefore, there was discussions between the two boards about bringing the two organisations together, because the visions are aligned. The approach to strategic commissioning means you need great workforce that can really and harness that expertise and skills at local level at a much larger level in order to commission in that strategic landscape with often complex provider landscape. So it was felt that by joining with North Central London, actually we had better opportunity to have a resilient workforce that could do that strategic commissioning well. That's a very large integrated care board that would then be formed. So in July, there were independent decisions made by North Central London and North West London integrated care boards to proceed with the initial alignment and then merger of the two boards. So the population size covered, actually, I've just covered that for the two boards, if the coming together is around 4.6 million or something like that, around about 4.6 million, which is the largest population coverage in the country, not necessarily geographically, physically the largest landscape, but population covered would be the largest landscape. So it really gives an opportunity to do things really innovatively and really make a difference to all of that population and learn between North Central London, what they do well, and North West London and what North West London does well, and bring the two together. So over the summer, there's been a lot of work happening between the two boards to think about an implementation plan and what would that look like. This has been delayed slightly because there are some national conversations happening about funding for redundancies, for example. So there has been a delay. So the reductions expected by April 2026 of the Integrated Care Board back office functions has definitely been delayed, and that's some of the unknown that we are waiting further guidance on in order to move to the next stage. And on the 8th of September, and so there's more information that continues to come out. On the 8th of September, a model regional blueprint. So I talked about the model ICB blueprint earlier. A model regional blueprint was published on the 8th of September. And alongside that, some good practice documents about some of the unknowns of services that should be sort of transferred to providers in the future. There were these good practice documents that have been published around medicines optimizations, CHC, safeguarding, and SEND, and has a really important. It's really important that we keep a really close eye on what those mean for our future landscape, because they're so important to the local place level as well and our local population. So in the coming weeks, we expect a lot more work to be done on that, weeks and months, to be honest. So our new chair has been appointed by NHS England. His name is Mike Bell, and he will oversee the merged ICB from April, as of now. The merged ICB as of April, but he has already taken on the role of the chair of both North West London and North Central London. On the 12th of September, Rob Hurd, who was the chief exec of North West London, ICB, left, and very soon after that, in fact, the Monday after that, Francis O'Callaghan was confirmed as the chief exec of who is the current chief exec of North Central London, who would take on the chief exec role for North West London as well, and would be the chief exec for the joint merged ICB as of April as well. And an executive team consultation is currently underway, and we are waiting the feedback on what that structure will look like. Staff consultations will start after that. So as you can imagine, it's really difficult for all of the staff who've been through a lot of change over a number of times, but it just it's difficult and morale is low. But I'm really pleased to say that our local teams are working really hard, because their true value for working in the public sector is to improve outcomes for the local population. So I'll move on to the next section. So the 10-year plan that was published earlier this year sets out an ambitious plan to redesign how care is delivered, with 3 shifts from hospital to community, where a lot of spend happens in the hospital, but trying to shift some of that activity and spend into the community. From analog to digital, so this is really trying to improve the digital landscape, and from treatment to prevention, which was music to a lot of our ears, because that focus on prevention means that you have it's better than cure, right? That's what we all say. So and personalising care and giving more power to the patients, and ensuring the best of the NHS is available. So I'm going to just explain in a moment what that means from a local level and what we're thinking about at a local level. So these are the 3 shifts that we've been talking about. AI is definitely a big one that is happening everywhere you look, but there are huge opportunities within healthcare as well as other digital innovations. And from hospital to community, we've talked here in this scrutiny committee in the past about easier access to appointments in the GPs. I'll talk about neighbourhood teams in a moment, but there are opportunities to really think through how you design care much more closer to home. and sickness to prevention, as I said earlier, and we're already we know that makes such a huge difference. I won't go into this slide, but this is some of the detail behind some of those delivery plans around those 3 pillars of a shift described in the 10-year plan. So what does that mean for us locally at an Ealing level? I've mentioned neighbourhood health in the past, and I've mentioned neighbourhood health, and it's come up in some of the slides here. It's a big part of the 10-year plan design for the future. What does neighbourhood health mean? What we're trying to do is rearrange some of our teams to work more closely with the local population, create teams that are multi-agency, multidisciplinary, at a more local level, serving geographical populations of around 50 to 100,000. It looks really well with the connected communities agenda that the council are undertaking as well. But in those smaller teams, you would have core services that are working much more closely together. But you would also have an integrator function that's helping that neighbourhood really work at a local level. So this brings together health, care, public health, all of our data at a much more local level with a no wrong front door approach, and really improving the seamless care between different organizations. This is the ambition that we're trying to work through, and I won't go through all of those points in there. So we've been on a journey. I would say this starts way before 2022, where in Ealing, I think we've been on a journey of integrating care at a local level since 2012, I would say, or even possibly even before then, where we had the integrated care pilot and we saw some really positive outcomes. We've had care coordinators as a team emerge from that scheme. When COVID hit, we were it brought us to a different space, but we saw the value of working at a local level and speaking to local people was really important. But since 2022, we've had an established borough-based partnership with all of the partners that we've mentioned before are around the table, health and care. And it's just grown from strength to strength. We have honest, transparent conversations and really hold each other to account and try and solve problems together. We have an Ealing Care Navigation Network, so you hear about social prescribers, link workers and all sorts of people working together. They're working much more closely together, and we've done some really innovative work supporting housing on with homelessness, for example. We're doing some work on alcohol usage, and we're really trying to work at a closer level. So there are a number of documents that describe the benefits of developing these types of neighbourhood teams, and there are lots of international as well as national examples of why this is a better way of working. So for Ealing, we have primary care networks who are organised at around 50 to between 40 and 100,000 population already. So as a collective, we agreed that we would use that same geographical footprint of our primary care networks to establish the neighbourhood teams on top of. So we're building on an already existing framework of working. The local authority has the 7 towns agenda, and we have our 8 neighbourhoods. They're not totally overlapping, the 2 geographies, but we recognise that, and we'll gonna actively work on making sure that we find ways of working at that local level, and that these 2 sort of ways of organising ourselves don't work against each other. Actually, I think we can really make this work positively, because everybody is trying to work more closely to the local population. We couldn't use the 7 towns approach because, for example, the population of Perivale is about 19,000. That isn't enough to create a resilient health and care team that can focus on providing care at that local level, whereas the Ealing population is about 90,000, whereas the primary care networks, or so that the 8 neighbourhoods are more aligned to that 40 to 90,000 population, so it's more able to do that. And this is the type of model we're trying to deliver. It's a very detailed diagram, but it just all I'm trying to describe here is the population is the most critical part of this, which is the base of everything. We're trying to organise ourselves as health and care providers to provide better care more seamlessly and integrated for our population, and doing much more of the preventative work at a local level, provide more proactive routine care as well, and where people need emergency and crisis care, that is available, that is ready, but then we're stepping people back down into that more proactive care model. This is the last section you'll be pleased to hear. So I talked about integrators earlier. So in order to realise these types of change, massive gateway transformations that we're trying to do across the whole population, and with the changes happening to the integrated care board and not having a much more local team, what we have been asked to do as a local system is identify an integrator organisation, and they would host a team that could then drive some of this function forward. We are expecting some national direction around new contracts at local, individual, neighbourhood level, but also at a place level, so the whole of Ealing that would cover. So we'll wait for those. But each partner brings different things to the table. So social care and local authority bring different things to the table. Community services bring other bits to the table. General practice and primary care as a whole, with dentistry, optometry, and pharmacy, bring different things to the table, etc., etc. So we need everybody to work in a much more cohesive way, with a joined up agenda and a joined up vision to drive forward the ambition of the local population. And this slide just describes some of the role of that integrator, which I've already talked about in detail. What we have agreed, however, is that, okay, we will nominate one organisation to host the integrator function, but what we are really keen on doing is having a partnership board that is actually making the strategy come to reality and really drive some of that decision making, which would include all of those partners that I described earlier, and they would all deploy leadership and resources, and this is a critical part of any integrator thinking for the future for us in Ealing. They would have, each of those members of that system would have shared and equal governance, and we're all working to drive improvements in outcomes for our population. And we've done some thinking about having a core integrator team, which has very key skills to help us drive the agenda, and a more extended team that each partner is committing resource to. And this slide just sort of tries to describe that in a bit more of a diagram. So the core integrator team would enact the decisions of the partnership board, have that business intelligence across us all collectively, so we know our populations and data, and really support the whole system to function. The integrator organisation that we have nominated is West London NHS Trust, who would provide corporate governance, clinical governance, human resources, and host some of our services at the moment. The extended team, so if one partner has really strong communications teams within their organization? Can we pull on their resource for the whole system? Same with engagement or managing estates, digital, etc. And all of this the strategic assurance would be provided by the Health and Wellbeing Board. So that's a really important part of the whole system thinking. And the statutory boards of each partner would deploy their leadership. I won't go into this slide, but what I'm been trying to describe here is actually we've been working in this way since 2022. So it's building on what we've been doing and doing really well as a partnership. The partnership has really grown, and I'm sure the partners will want to come into that, but we still have some unanswered questions as well, which is that final column. So before we can move further, we need some of these questions answered. You're pleased to know that's end of me talking.
No problem at all, Neha. That was really comprehensive, and we're really grateful to you for the level of detail. I'm going to move into questions. I will just point out before I do move into questions, however, that you'll all, colleagues, will appreciate that there's quite a lot of emerging thinking that's happening at the moment. Whereas normally I would be saying hold partners to account in a robust way. Tonight, I'm actually saying there may be bits of information that are yet to come. So we might need to seek assurance with responses to come back. Now, Neha, that's not us letting you off the hook, but we are aware of the situation that's evolving. So I'll go to Councillor Conti, and then I'll go to Goulet and David after that.
Thank you, Neha. It was for the really detailed presentation. This isn't aimed at you, but it's even working in NHS, I almost struggled to follow and understand any of what was really going on. I think, and this isn't a party political point either. I think whatever government of any colour, they come in and they just want to change everything and restructure and reorganise. And you've got integrators, PCNs, neighbourhood teams, ICBs. It just seems it seems so complicated and almost unnecessarily so. I don't know, you could have read Shaping a Healthy Future in 2012 and the objectives would have been almost the same, and it sounded like reading exactly the same thing. And so I guess I wrote down a whole load of questions, but I guess that the main question, really, to summarise, would be two. Is one, well, what are patients going to actually feel that's different? What are residents going to feel that's different in 2, 3, 4 years' time? And what are the obstacles to still achieving the same thing? Because we've been talking, I remember sitting here, I think in 2015 and Health Scrutiny, when there was different people from the CCG at the time with talking about exactly the same things and saying we're going to integrate with different partners, we're going to move to preventative medicine, we're going to do this. And we're now here, 10 years later, and we're talking about the same objectives. So what hasn't worked? Why are we still on that journey? And what are the obstacles? Because it just seems like I'm listening to the same presentation being given by different people.
Who wants to have a go at that one?
Partly because Neha's done a lot of talking already, I thought I'd let her off the hook by attempting to give a provider lens answer to that, if I may, and others might want to come in as well. I guess I take the I recognise absolutely everything that you're saying, Councillor Conti, in terms of the themes and the narrative that are within this. I guess as a provider and as a practitioner, I also take some heart in the fact that the work that we have been doing during that period of time and the things that we always thought were important about trying to join up patients' care, to shift the setting of care to the least restrictive or the closest to home setting that we can, and to use the resources that we have available to us in the most efficient way, are still the ones that we're being asked to pursue. So I think I took some heart in the familiarity, I suppose, of the plan, whilst also acknowledging that there is organisational churn and redesign at the heart of this, which I suppose I would frame as extremely challenging. And I think Neha understates the impact that it's having on some of her immediate colleagues who are all, going through a considerable amount of uncertainty as headcount reductions are trying to to make savings at that level of the commissioning tier. But from a provider perspective, and Simon might have a view on this as well, I think what we are seeing is the potential, well, hopefully a way of buffering some of all of this change from the frontline staff and the patients that they're caring for, because the work continues, I suppose, is the first message that I would say. I think the second thing is and in the few years that I've been on the board at West London Trust, I've had to learn quickly how we were governed, regulated, scrutinised, our contracts managed, and I'm seeing the new oversight process as both a opportunity and a new challenge, in that there is a return to earned local autonomy by organisations. So if you can prove that you are delivering the things that are defined by the people that define these things as important, they are giving you an awful lot of ability to make decisions about how we provide care locally as an organisation, and here as a borough-based partnership. So I think there are challenges with that, but I do see it as an opportunity for us to work out, well, actually, those of us in this room know the residents of Ealing and what we think we can provide within the resources that are available to us that will best support their care. I don't know if others want to add, but I guess the one bit that I haven't answered that you did ask was why hasn't this happened before? And I think that's a really fair challenge. I think that I'm not sure we have pushed the button on having an integrator at place that is responsible for, contracted to, held to account with deliverables for the population. We've talked about working informally towards it, but it does, and maybe I'm naive, but it does feel as though we are getting to the point where actually there will be an expectation of delivering some of this in a way that before was an aspiration.
It's really helpful, Chris. I've got Kerry, VJ, and then Councillor Newstab to answer that question, and then I'll come to more panel members. Oh, and Simon wants to come in too. So as always, I'm going to say punchy answers. Thanks, and I know Kerry, you will be.
Really good that Ealing as a system is answering the question, which I think is a really good reflection. The punchy answer is, I think, Councillor Conti, why is it different? Is we're seeing a significant reduction in the commissioning function, which is being drawn further away, which leaves the system to resolve the issues and to develop the model locally. I think that's the bit that's really different. And I think the blocker that we may face is how we are really clear about the commerciality and the system benefits. Because at the moment we're all reporting up and then coming back down. If we're working together as a system, we can see the flow of activity and money within the Ealing system. I think that's where the real opportunity is for us, and that drives the better outcomes for our residents.
Thanks, Kerry. VJ.
Yeah, I just wanted to add that on a positive note, what these changes are enabling us to do is, one, from a local level, really strengthen our partnership, and that has been evident in terms of some of the work we've been doing in relation to preparing for the changes that are going to be happening. But wider still, we've had our acute provider collaborative, our community provider collaborative, our mental health, and now potentially our primary care collaborative developed and strengthening, so that there's much more alignment of how our providers are working within North West London and within the health landscape, so that there's that common vision, that common goal in relation to how we deliver health and care provision and to ensure that we get these good outcomes. You're absolutely right. We've been talking about integration for at least 15, 20 years, and we've still not been able to actually solve integration. We've done a lot over the last 5 to 10 years in what we would describe as small parts in relation to how we deliver clinical pathways. But however, this is now the opportunity for us to do some real wholesale changes in how we deliver neighbourhood health, but it will require investment, it will require resource, it will require a change of culture in terms of how we deliver healthcare provision, and also there will need to be a level of shift of resource from our acutes into community, because there isn't, if you think about it, there isn't vast amount of new money, and a lot of what these changes that are happening is because financial budgets, financial constraints makes us consider how much more efficient we can be in terms of delivering the best outcomes for our population.
So I'm going to come to Councillor Newsted. I think this is a really important discussion, so I'll then bring in Simon and Anna, and then we'll come to Goulet. So Councillor Newsted.
Thank you, Chair. And again, thank you to everyone in the partnership. Every time I see everyone, they look slightly more tired than the last time. But we do value the work that you're doing. I mean, you look lovely. You don't look tired. You know what I mean? I'm just trying to be sort of sympathetic and empathetic. But for me, I think this is my first rodeo on this, so I can be optimistic about what the changes will bring. But there are several kind of unanswered. There are a number of unanswered elements to that integration role, and one of them is around political accountability and the role of the local authority, because I think we're very adept and used to working as a borough-based partnership. We are lucky enough to have excellent relationships when we're talking about hospital discharge and so on. What I don't think we've yet cracked, and what I am very focused on as health and wellbeing board chair, is that we start focusing on some of those wider determinants of health that we know are the things that are going to stop people ending up within the NHS in the first place. And until we collectively, as a system at a local level, because integration really only happens at a local level, if we need to be pushing ourselves into that space far more effectively, and to that end, I'm happy to come back at a later date, because I think it probably does deserve some greater scrutiny, is that we've been alongside the LGA doing a series of workshops to get everyone in to kind of say, actually, if we stopped all retreating to our safe space of VJ saying that the hospitals need to give him more money, and that's no criticism, you're absolutely right, but we are all very adept and at sort of either identifying problems but not then coming up with solutions, and perhaps not prioritising things for our residents as well as we could do. I'm very keen that we create more grit and tension in that system, and that we are really focusing on prioritising the real world things that we can do. And we know that when we talk about connected communities, very easy to say, but we also know that everything we can't do well is going to rock up at the door of the NHS in future years. So I think we have a huge role in that prevention agenda. I'm very optimistic that we can start, once we get through all this turmoil, that the integrator function and our role in it, as well as hopefully people like myself being a bit more bolshy and pushy in that system, and collectively we all have a role to play in that, will start driving some of that change, because we don't have to, as Kerry say, be worrying about all that stuff that's happening over there, which will hopefully free up more time to be actually focusing on outcomes at a local level.
Thanks very much for that. Couldn't agree more. I think the challenge is always that difficult issues get put off for tomorrow, don't they? So Simon.
Thank you. So the why, I think, is public finances. Is definitely one of the reasons for the change. I think also accountability as well, and sort of control and grip, moving away, if you like, from NHSE and closer oversight to the Department of Health is part of what this is designed to achieve, and we're seeing that with the new oversight framework for providers that Chris alluded to, and different segmentation in terms of rates, performance, and ranking organisations into sort of 4 buckets currently, but a 5th potentially for vastly underperforming organisations. So I think that's part of the reasons of why. I think in terms of the integrator model, I think that is a positive step forward in terms of, we all work in partnership and have done over recent years, certainly post-COVID, in a more conciliatory way and supporting each other. But ultimately, I think having one organisation helping to drive and be the link in terms of holding us all to account, I think is quite important. And I think at the end of the day, that should come out of the fact that we've all contributed to the discussion around the role and function of the integrator. It's early days, clearly, yet they haven't been formally be established. But I think the framework for taking that forward ought to be positive, so long as we get the right behaviours across us all in terms of working together. But I could say more about the oversight framework if there was time, if you wanted me to later.
Thanks very much, Simon. So I'll bring Anna in, and then we'll see what Councillor Conti's verdict is.
Thank you, Chair, and evening, everybody. Apologies in advance, I'll have to sign off after this, but I just wanted to come in as part of that system answer as well. I think Councillor Conti's questions really valid in this situation. I think just touching on what a few other colleagues have said, it does feel like this is a bit of a tipping point. Neha and I were talking before about aspects of this neighbourhood working. I think where you've got a real focus on actual prevention in the 10-year plan and that focus on neighbourhood working, and then locally we've got really good joint working under the health and wellbeing strategy, really thinking about how we work together in terms of the building blocks of health, reducing inequalities through partnership working, connected communities vision, huge in this, lots and lots of examples of working at that neighbourhood level and community-led change in this space as well. I think it's for us now as a system to really pull that together strategically and really have that clear vision of how we support communities and supporting them to lead change at the neighbourhood level. So I think with that integrated function, a couple of colleagues have also touched on this, that does feel like a difference. It feels like there's a lot to work out before we get there, including the financial envelope and the functions and clarity around that, like you were saying, Chair. But I think with that coming locally, I think we're well set up for that here with the way we've worked in partnership already, and that more formal governance I think will be a really good positive step. Thank you.
Thanks, Anna. Any follow-ups, Councillor Conti, or are you reserving judgment?
Sort of reserving judgment, really. I think it's interesting, the idea that is the integrator was the missing block to enable that. But I would have thought, in one sense, wasn't that what the ICB was supposed to be? The thing that was supposed to unlock everything, to allow everything to work together. So I remember when I was sitting on House of CCG, that's what they told us at the time. So that's what the great thing, the panacea down the road. So I don't want to sound overly cynical. I'm sure that it's all the great intentions, but obviously council elections permitting, from here in 2 years' time, it'd be interesting to see what if there's another reorganisation, we haven't got this, we're not saying the same things again. But we'll see.
I tell you what, we'll invite you back regardless. We'll go to Gule next.
Thank you very much. I've heard what everybody has said, but as I'm the co-chair of the Carers Co-Production Board, my questions are more focused towards unpaid carers. So unpaid carers are the backbone of our health and social care system in Ealing, and yet they face poorer health, greater isolation, and often feel excluded from decisions about the care they provide. So as we look at these major changes in the health landscape, the merger of ICBs and the shift to neighbourhood teams, the new integrator role, it's vital that carers are not an afterthought. Their voices, well-being and access to support must be built into this new system right from the start and not bolted on afterwards. So my main questions are, all the integrated care boards are required to reduce their running costs to a maximum of £19 per head of population. What I'd like to know, what is the current amount at the moment per head, and delivering within the £19 cost envelope presents a challenge and risk, considering that the minimum pay, average minimum 1 hour pay is £12.21. And so what does this £19 expected to cover? So my second question is representation in the system redesign. So the ICBs will focus on strategic commissioning while neighbourhood teams and integrated take on more delivery and coordination. How will unpaid carers be represented in this new governance and decision-making structures? So their voices shape how services are designed and commissioned. And the next question is about neighbourhood teams and carer support. Neighborhood health teams are being set up to integrate GP, social care, mental health, and voluntary services. What specific steps will be taken to ensure unpaid carers can access support easily at this local level without having to navigate fragmented systems? And one last question.
I think three
Yeah.
in one go
Yeah.
is probably enough for just now for people to be getting into, but you will have the opportunity to follow up afterwards. Pause for breath, and we'll go to Kerry or Neha to start.
So
Neha?
I'll start with the amount. So currently, Northwest London is about, the national calculations have been done. Northwest London is about 41% above the amount we need to achieve. So if my calculations are correct, it's about £26.6 per head. So we have to get that down to £19 per head. That varies vastly across the country and all of the ICBs, and North Central London is further away from that distance than Northwest London at the moment. I think you have some really, really important questions, and I would really like to take you up on having a conversation outside of this about how we do make sure that we are building carers' thoughts and their needs right from the outset. They are already a really important part of the system, and we do a lot to try and recognise that. But if that's not being felt, we need to make sure it is. So I'd really like to explore your thoughts on that, and maybe with the Carers Partnership Board.
Kerry, I'll come to you.
Thank you, Chair. Thank you, Gule. I think the role of the Carers Partnership, as with all the other partnership boards, is key for us as a group in terms of the Scrutiny Committee. I think we've got the representation from health and social care in this space, but it's been really clear how we use the co-production board function going forward. We've got the co-production boards that Conor and Gule are the chairs of within the council. Chris will have his co-production boards. Neha and Vijay will have their engagement with their local patients. We need to have a more coherent and consistent approach to how we do that engagement. So it's absolutely the right challenge. I think we've got it right having both of you here, but we need to have that more consistent piece in terms of the Ealing picture. Sorry, Simon's probably got co-production boards as well.
Elaine, any follow-ups? That's lovely. So we've got about 10 minutes left for this item. I've got David next, then I've got Councillor Dinser, and I've got a couple of questions myself. So David.
Thank you, and thank you for the report. Given the reduction of staff and moving to a commissioning model, what do we envision meaningful patient engagement looking like after this is all said and done?
Chris, I think the mic's been pointing in your direction.
David, I think you're making a really important point, and I guess there are a number of changing aspects, because and Neha will be very familiar with the direction of engagement in the model ICB and the regional blueprint, and I think the intention is to try and push that much closer to communities and to both the providers where they are hosting an integrator function, but I see that very much as providing that hosting arrangement for the borough-based partnership as it matures and becomes the place that drives health and care for Ealing residents, and not just the people who are Ealing patients currently, but people who are residents who may potentially become future patients, or who we hope to prevent from becoming future patients. It's worth acknowledging the changes that have been announced recently to Healthwatch nationally. And again, I think we need to think locally and with you and your expertise and the co-production boards about what we will lose and what the Ealing future provision will be that gets that voice into all of the right spaces to define it. So I don't actually know the answer yet to your question, but I think we need to have that conversation together to actually define it as a way of kind of modelling how we would like to work those conversations in future.
I think that's really helpful, and I think a practical action that's probably stemming from this is a specific discussion between Healthwatch and colleagues sat around the table as part of that partnership working, so that we can thrash that out. David, anything?
No, I just wanted to thank you for the response. Yeah, we'll have a conversation.
Councillor Dinser, coming your way.
Thank you, Chair. My question is in the context of Southall, where a lot of people are not competent in using online services. How would you make sure that people who haven't got the confidence to use online services and or the internet, how will you make sure that they get the same level of care as the people who can use digital services? And the second question will be, in terms as a patient, these changes, how are they likely to affect us? Are we likely to see faster GP appointments, or are we likely to see better access to neighborhood services? And the third question will be, I won't ask the fourth one. The third question will be, how will you check that these changes are reducing health inequalities? How would you check that? And would you be able to share that with us?
Brilliant questions, Chris, if you get us started.
I'll have first stab, and colleagues again might wish to come in. Thank you for your questions. I mean, I think the point that you make about digital inclusion is a really critical one, because we absolutely in the plan, and I think all of our organisations are committed to trying to move as much as is feasible to digital platforms to support access, to make services more accessible, to make some of our services more efficient, and to use some of the new technology that will free up time for clinicians to be able to provide more care. But that cannot be at the expense of making the services accessible to individuals who are unable to access digital platforms, or who are not familiar with digital platforms, or who have other barriers to accessing the digital solutions. So there will always be a non-digital NHS that will always be available to have alternatives. So whilst we applaud, I guess, the aspirations of having the option to do stuff digitally, it can't be the only front door to all of our services, and it can't be the alternatives can't be an inferior one. I think the comment you made about GP appointments is as an example. I think one of the pieces of work that we're doing in relation to developing our neighbourhoods is about broadening not just GPs as a specific profession, but the whole of the multidisciplinary landscape, the lots of different health professionals, and not only health and care, and also voluntary sector partners that work in communities, how we can make the team work for neighbourhoods and therefore make those appointments more accessible. And then I think the final point is, you're totally right that we can't do this in a way that excludes individuals from different neighbourhoods, from different communities with different protected characteristics. And I think we need to be held to account for making sure that the access and the experience and the outcomes of our services are equitable, and we are trying to build that in. All of us are trying to build that into what we are measuring. There is some way to go to build the maturity of that, but in our data systems and in how we capture the information. But we absolutely want to share the ideas, and if others have ideas, I think please be sharing them with us.
Great. I've got Councillor Newstep and then Neha.
Thank you. I'm just going to point to I I really take on board your point about, like, there are 5 million more GP appointments sorry to bring a political point, that have been made available, but actually that's only one part of the solution, right? Actually, we want people to be able to avoid a GP appointment if possible, if there's another more appropriate place for them to be seeking support. And we know that a lot of repeat GP appointments are less necessary. So if we had more social sort of options available for people, that might well meet that. The inequalities piece is really interesting. So this is where I see we have while overall on average Ealing doesn't perform terribly badly on our health outcomes, within the borough they are appalling. We have over 7 years life expectancy difference, and we have wildly varying rates in terms of screening, cancer diagnosis, all sorts of things. And it is all readily available on the Ealing Data Health Inequalities Dashboard, which I would really recommend if people don't know about it. It's easily Googled and found, because that really does illustrate in really stark form some of the challenges that we face in Ealing. So my view is that we need to be thinking about what data we want to see in those kind of forums, but also how we can make it much more real time. But really, for me, that's where we go as a health and wellbeing board who can direct that strategic direction, is how do we establish those priorities? And if you've got a sort of the system here as it is, alongside our brilliant voluntary sector and all the other parts of our organisation and the wider system, if collectively we put our minds to some of those in very focused ways, with a little bit more of a sense of the crisis that it actually is, then I think we could achieve an awful lot. And I think having that at an Ealing level gives us significantly more latitude to do things that are creative, innovative, non-statutory, but actually really might be focused on solving the population problems that our own population have. Thank you, Chair.
Lovely. So I've got Neha, I've got Councillor Bates, and I've got questions, and then we'll have to bring the discussion to a conclusion.
Thank you. And I just love that all of the partners are giving all of the answers, which is fantastic, because we are all speaking from the same page. I just add one or two things. I think that's where public health can really help us as well as our BI colleagues. They have some expertise in looking at that data and supporting us in understanding the needs of the population, developing joint strategic needs assessments that we can work on and really check, are we making a difference? And the only other thing is around that analog to digital. There are efficiencies that can be made by adopting some of these technologies, and I think that's the major focus that we need to happen. And if we're making those efficiencies, it should improve the productivity and therefore hopefully the access.
Thanks, Neha. Councillor Baines.
Thank you. This is just a comment or question. Just want to say thank you very much for your reports. It's very detailed, and I think such a big change in communities does take time, and it's so positive actually that we are reviewing this time and time again. And I am looking forward to seeing this in the future, because we're holding accountability. We're also regulating what we're doing and what decisions, and taking in all of the opinions on our partnerships. So I think it's very important that it's reviewed regularly. So I think it's very positive that we're bringing care into the community so that residents really know what their needs are. Thank you.
Thank you very much for that, Councillor Baines. And then I think just the final challenge from me in terms of because we're going to have another follow-up discussion on this area next time, because it is evolving and new thinking is emerging. But I think there's a specific question that's relevant to this committee about the relationship between HASP and the integrator moving forward, and actually the practicalities of holding that partnership to account. So I guess my takeaway challenge, not necessarily expecting comments and reflections on it now, is that we all collectively think about that in advance of our conversation next time, and start to think, because I do, when I go off to Northwest London JOSC, the majority of the partnership that we've got in Ealing is really effective, and the way that we scrutinise, I think, is seen on a Northwest London level as being exemplary. So what I wouldn't want to do in sort of the changes is lose that. So I think we just need to think through the model for moving forward and how we would hold the integrator to account. So collective piece of homework for everyone, if that's all right to think about for next time. As I say, we will have a follow-up discussion at the next panel meeting. But I just wanted to say thank you, Neha, thank you, Chris, VJ, Kerry, Polly, and Simon online as well. Really appreciate all of your input on this item this evening. Thanks. So with that, we'll move on to adult social care performance. another equally as chunky item. Kerry, I'll come to you just for a brief introduction and then standard format, inviting questions from colleagues around the table.
Thank you, Chair. So members of this committee will know that this is a regular cycle of bringing reports in terms of the overall performance in adult social care to the Scrutiny Committee for your overview and scrutiny of performance and to answer questions. This report is the next iteration of the cycle of activity. There's been some slight changes in terms of the performance reporting, but that's by the nature of the system as we work. Just to give you some very high level highlights in terms of the performance in the service, colleagues in the NHS are very aware of the performance. We talk about this regularly with them. Just to give you some highlights in terms of the performance and the changes within the system. Within the social work process, there's been a significant piece of work focusing on the customer journey, which means we've restructured services and allocated resources to respond to demand and also backlogs. The resident journey has seen an elimination of backlogs at first point of contact, triage in terms of activity, triage of the activity at the front door has seen a reduction in waiting times within the service, as well as a reduction in the median waiting time and longest waits for the services. This has been supported by where we're shifting resource from one area of the service to another to really reduce an impact on the delays in that area. That allows the service then to restructure and remodel based on lower levels of demand and pressure. At one point we had thousands of CGASMs within the system. Obviously that takes a lot of pressure onto the front door and people are focusing on dealing with the backlog. By releasing that pressure on the system, it's allowed the system to become more efficient and to improve the processing. Also included within the report, there's information here on customer satisfaction surveys, the CQC rating of our registered providers within the borough, and other activities that we carry out, including our financial activities, safeguarding and deprivation of liberties. I'm not proposing to go through the entire report, Chair, because it would take all night, but I'm really open to take any questions from colleagues around the room, and questions that I can't answer immediately, I will aim to get a response to you as soon as possible.
Well, Councillor Baines was straight in there, so straight over to you. Thanks, Kerry.
Thank you. Thanks for that report. Yeah, just a quick question about staff reductions and what this means to balancing that with quality of care. And also, as winter's approaching, what does this pose for the pressures in the system? Thank you.
Thank you. Should I answer that one straight, or do you want to?
No, happy for you to.
Thank you. So, thank you, Councillor. The reduction in spend of headcount is spend on staff rather than headcount and staff. We've made a shift between Ealing Social Services has always been highly dependent on professionally qualified social work staff, and we've made a decision to have a shift to increase the number of unqualified workers in the space. So we've reduced the headcount in terms of social workers, but increased the headcount in unqualified workers in the space. They don't carry out the professional functions of a fully qualified social worker, so that's safeguarding, court work, etc., but they do carry out a lot of activity within the community, so we're getting greater productivity as a result of that. We've also seen a lot of work done around the use of AI in our assessments at the front door, and that's reduced the admin time within the service by 40%, which is significant. So that capacity is now being used to support more people within the service with fewer staff but greater productivity. In terms of the winter, we work very closely with NHS partners. There's a lot of planning going on at the moment in terms of preparing the sector with immunisations for COVID and flu, and we're working with partners in terms of the care homes there. Also working with Simon's teams constantly to keep a very close eye on what the discharge flow is looking like from North West London, but also all the other hospitals that we serve in Ealing. We've got the most complex NHS pathways for Ealing residents. You can go to 5 or 6 acute sector hospitals, but we work very closely with them. And I would go so far to say that we have good performance, but I'll leave Simon to comment on that. It's very challenging, but there's been a lot of good work done over the last 18 months in this space.
Simon, did you want to come in on that?
Yes, I'd echo that. So 18 months, 2 years ago, we did have some significant challenges in terms of peaks and troughs. I think it has significantly improved from that point. Inevitably, with the scale of pressure that we've got in the NHS, there are days where it's not able to respond in the way we'd like, but equally we're not able to respond in the way we'd like because the numbers that we're seeing attending Ealing Hospital, but also Northwick Park. And sometimes when Northwick Park's under pressure, patients come to Ealing as opposed to Northwick. That adds to the complexity, and that's part of the complexity for Kerry when we're trying to discharge patients to other boroughs as well as part of the challenge. But yes, significantly improved over the last 18 months.
Thank you.
Excellent. Thanks, Simon. Is that okay, Councillor Baines? Yeah. Councillor Conti, I'll come to you.
Thank you. It's just about occupational therapy, because I think when you last finished the report, I think there was a particular issue with the length of time people were waiting. I know on the table it says the maximum wait time is 201 weeks. So I just wonder what the median, like the average wait was, and has that come down? Because I couldn't see where it compares it to the last time. Has that improved from the last time the report was presented?
Thanks, Councillor Conti. Kerry.
Thank you, Chair, and thank you, Councillor Conti. We have specific areas of challenge in the system. There are some of the therapeutic inputs for people with sensory impairments, and trying to recruit the staff to respond to the level of demand we receive is still a significant challenge. The overall performance in terms of waiting times is impacted by 2 smaller areas, which is the sensory impairment response and the occupational therapy. As you'll recall, Councillor Conti, we've been through cycles with the OT, occupational therapy, waiting lists, and some of that's a product of it being very difficult to recruit and retain staff in that space for a particularly long period of time. We're building back up within the cycle and put additional resources in to reduce waiting lists. We've just had agreed additional funding to support that in the last 6 weeks, and we're recruiting staff currently, but there's specific areas, and it is within that therapeutic inputs where staff are very hard to find.
Thanks, Councillor Conti.
Can I just come back to what is you don't have to, if you can email like the circulate, but what is the average waiting time at the moment? Because I'm assuming not everyone's waiting 201 weeks. What do you know approximately what that
so that will be the I think that's the longest wait, but let me come back to you. We've got the median waiting time waits are within the report, but I'll come back to you with the detail on that.
That'd be great. Thanks very much, Kerry. So I'm going to David Goulet and then Councillor Dinser.
Thank you, Kerry. Wholeheartedly encouraged by all of the good progress shown in this report. One thing I really like is the resident journey, making it more efficient. Is that a piece of work that is just internal, or is it something that's being promoted to residents, that this is how it should work in adult social care? And if it is being promoted to residents, is it being promoted to all aspects of our community in different languages and such?
Kerry.
Thank you, David. We're about to go live with what my colleagues are calling an infographic, which shows, I don't really understand it, to me it's a river of performance, which shows waiting times at the front door, completion of assessments, reviews, which is effectively the customer journey through the service. I need to double check if we're putting that out in community languages, because I'm not sure we've done that as yet, but I'll double check that with you and come back and confirm.
Thank you very much.
Great. Goulet, please.
Thank you. Thank you very much for the report. And it's great to see that a lot of performance has been captured and a lot of time must have gone into capturing all that and producing the report. So my questions are that I have seen some gaps in the report, and one of it is the missing carer outcomes. The report tracks things like assessments, waiting times, and placements, but it doesn't report on whether carers feel supported, consulted, or able to maintain their own well-being. And when can we see this performance reporting? And will we see indicators that reflect their health satisfaction and involvement in care? My second question is missing carers assessments data. We see detailed figures on resident assessments, but no data on carers assessments, despite the duty to identify and support carers is under the Care Act. Why isn't the number, timeliness, and quality of carers assessments included here? And how will this gap be addressed in future reports? And the third question is missing support on carers' health inequalities. The report mentions improvements in safeguarding and reablement, but says nothing about tackling carers' health inequalities, despite the just evidence of high risk of poor mental health, musculoskeletal problems, and isolation. How will the adult social care embed carers' well-being, things like respite breaks, mental health support, and health checks into performance framework? Thank you.
Great. That lot will keep you going, Kerry.
Thank you, Chair. Thank you, Gule. Gule did share these questions with us prior to the meeting, Chair. I've got a very detailed response, which I propose to send to Anne-Marie to send out with the minutes of the meeting. Is that okay? Because there's some very detailed information in terms of Gule's questions. The questions that were raised are very pertinent in terms of our response to carers' needs within the community. There's ongoing discussions with Gule and the carers group in terms of the carers strategy and also the surveys which are going out in January. So if that's okay, Chair, because there's some very detailed responses if they go out with the minutes.
Yeah, that's absolutely fine, and we can pick up any other queries that stem from that at the next meeting. That'll be grand. Councillor Newster.
Yeah, I mean, I think it's probably in terms of detail best for Kerry to distribute, but there is your point about the performance framework is really interesting. It's a really interesting one because we will take various things that I don't know have been in there for all time, are statutory, are based on various other regulatory performance capturing devices like ASCOF and so on. So it is really useful to start thinking about what those gaps might be and how we start to fill them. But not only, it may be that there are other things missing. So as a collective kind of thought that you know we present, I don't know how you've devised these reports, but like you know there is nothing, there'll be some elements that are statutory, but like if there are other things that people want to see, it's a really helpful and useful reminder that we can make those demands of Kerry, and I'm sure he'd be happy to respond.
He's very happy to respond, I can see.
And just to say, a lot of the information here is it's not technical, but it's internal business information that we use to run the business. So a lot of it is about numbers, it's about turnover, it's about speed of response, etc. And it doesn't answer a lot of the questions that you're raising, Gule. So we've been in a cycle. I think we've done it for the last 4 years where I've brought the performance reports to HASP. I think it's really positive because it's open and it brings scrutiny into the system. But maybe there is a discussion in terms of future reports, whether restructure it slightly differently. I'm not sure, Chair.
Can I go again quickly?
Just let me have my own thoughts just for a second. I think we can spend a lot of time quite often on the format of reports, and actually what this provides to my mind, and certainly from a kind of healthcare regulatory perspective, it provokes a conversation about some of the other issues. So, I mean, there may be specific areas that stem from the more detailed responses that Gule says, yeah, do you know what, actually, we need to include that on a yearly basis, and we start to look at those metrics coming through. But I think the shell of what we've got actually enables us, with that transparent approach to sharing kind of management information, fulfill our responsibility as a scrutiny panel quite well, but open to be challenged on that, open to other colleagues' suggestions. And Councillor Newst have had one.
Many thanks, Chair. And I think you're right, and certainly I wouldn't want to discourage in any way that exposure of what are essentially performance management internal reporting mechanisms. I would say, however, that and this is the conversations that I have with Kerry, we need to bring more joy and more people and a more people focused approach into the way that we think and report about what we do. It's not only because that's more rewarding and more interesting way to assess and analyze things, but because I think it then defines the way that a system, I'm really sick of using the word system as well, the way that we as individuals and professionals go about our business. You know, if it's more humane, it's more and there are lots of organizations. I'm going to make much the same point when we come to direct payments. It's about it's about that individual and how we can meaningfully improve their lives, and we have to remember that. And I think if we rely on very dry reporting and we think about things as a system, we can sometimes forget that.
No, completely agree, and I think that's why in our scrutiny of the health of the borough report it works very well, because we've got those real life examples. So actually the narrative and the story is probably something that we can look to include moving forward, and I think that's really a helpful conversation. Now, Councillor Dinsey, you've been waiting very patiently, so I'll come to you.
Right, I think my question is similar to Councillor Conti. You know, the main report says the assessment was reduced from 19 weeks to 11 weeks, but the appendix says it's recently increased to 27 weeks. Am I misreading it? If it's gone up to 27 weeks, what are we doing to reduce it?
Harry.
Thank you, Councillor Dinsey. I think that's a reporting issue in the context of the report. It's not gone down and jumped up. It wouldn't be viable that it jumped up by that much in such a short period of time. Can I come back to you on that? Thank you.
Excellent. Yeah, no, I think it would be really helpful to clarify that point. We have got a wee while longer. Has anyone got any other questions? I know that Roy from ERSCAG, you've got a couple of points that you'd like to raise, so perhaps I'd invite you to the table. Over to you, Roy.
Well, actually, you've covered quite a lot on waiting lists and delays, but there was a particular point I wanted to make, just to say that the assessment weights were a concern for the Care Quality Commission last time round, and it seems that the median assessment weight has remained static, but the number of overdue reviews has increased. So the question is really, what action is planned to reduce waiting times and speed up the review process? And the waiting times, especially as has been mentioned about the OT waiting list, but there's also the sensory impairment team waiting list is rather high as well.
How would you want to deal with that one?
Thank you, and thank you for your question, Roy. Yeah, we are concerned about the OT waiting list and the sensory impairment waiting times. As I mentioned earlier, we're recruiting additional capacity and to support with those waits. The therapists who work in sensory impairment services, these people go out and do an assessment when someone's first registered with sensory impairment, are very, very hard to keep hold of. We've had one for a short period, and we've now got another person we're hoping is joining soon. So there's active work within that space. The reviews performance dropped off during June and July of this year because the capacity was being used to deal with the delays at the front door. So we moved resource, and that's caused a drop off in the reviews. That resource has been returned into the reviews function and is a strong focus for us going forward. The target of completing all reviews within 12 months, within a rolling 12 months, that is a locally set target. But we think it's a really important one for ensuring that people's needs continue to be met in line with their assessment. So we are aware, but thank you for raising those questions.
Yeah, and I think effectively we're seeing a couple of areas really make the average waiting time increase, when it's in other areas it's within much more normal time frames.
If there's a shortage of
Roy, if you just use your microphone, that'd be great. Ah, excellent.
yes, if there's a shortage of specialists, are you able to use the voluntary sector at all in terms of helping with these processes?
We work with the Middlesex Association for the Blind and with Deaf Plus as contracting partners who we have good relationships with, but there's certainly certain statutory duties that we have to discharge.
Thanks, Kerry. And Roy, you've
There's
got
another
a second question. Yeah, happy for you to take
it. I think this has been mentioned before as well, but it's worth noting that residents in supported living and domiciliary care have reported well over 90% satisfaction rates, while those in Ealing care homes only mentioned it was only 60% satisfaction rates. So is there anything the council can do to follow up any concerns raised by the residents of care homes? And just as a supplementary, I'd quite like to know how the survey was done, really, because there's a lot of people in residential homes in Ealing. Was this only a small sample, and was it done by telephone or by some other direct means?
Over to you, Kerry.
Sorry, I was just going to sneeze.
Oh, pause on the microphone.
The moment's passed. Thank you. So I hope that's good. Thank you for the question, Roy. So the surveys are generally carried out by telephone in terms of how we contact our customer base to measure their levels of satisfaction. We're very pleased with the high levels of satisfaction with the domiciliary care space. We do speak to a lot more people, as you can imagine. It's easier to contact people by phone when they're living independently in their own homes. We've been aiming to contact 20% of residents. Our experience has only been able to engage with a few residents via the telephone. So there's obviously, and that's residents in care homes. So that's quite a challenging target for us to achieve. We've increased capacity recently within the contracts team who do the surveys and do visit the care homes and speak to people directly. The other strong focus is working with the care homes in terms of the quality of their work. And we know that 82% of all registered care services in the borough are good or outstanding by CQC, who are the inspectorate. We know that we've got high standards of domiciliary care within the borough, but the continued work to ensure that we can speak to residents to gather their views on and their experience of services is a major focus for us. We have worked in the past very closely with Healthwatch, who carried out interim views in residential care settings and are currently working with us in specific areas where we think there's potential areas of concern and quality focus.
Thanks very much for that response, Kerry, and thanks for the questions as well, Roy. Just at this juncture, I just wanted to say, not an item on the agenda, but colleagues around the table, many of you will know Eve Turner from Ealing Save Our NHS. She's been a frequent contributor to this panel, asking lots of questions, holding the health and social care system to account. Eve is leaving the borough to relocate elsewhere, and I just wanted to formally place on the record the panel's thanks to Eve, who I think has been a really strong advocate for health and social care services in the borough. So just wanted to provide that update and that thanks to Eve.
Ealing Save Our NHS is still functioning, and John and me are the current, at least today's representatives from Eastham, and we will try and get some questions together for you.
Brilliant.
Absolutely loads buzzing through my brain now.
Excellent. Well, thanks. And we look forward to continuing that relationship with Ealing Save Our NHS long into the future. So really grateful to Eve and grateful to you for taking forward the important work as well. Right. On that note, if there are no further questions on that item, Gule, one last word.
I just want the North West London team is not here, but over the last few months, as a visitor, as an inpatient carer going to visit somebody at Ealing Hospital, I've noticed there's not enough input from occupational therapists. And that's maybe one of the reasons the delays are happening, because everything is shelved off to the community people. And if right in the hospital, the occupational therapists were involved more in the patient discharge and heavily making them more active in the wards, then we wouldn't be building up such a big waiting list. And this is a significant big drop. Like literally, they're not visible anymore on the wards, the occupational therapists.
Simon, can you comment on that?
So we do have occupational therapists. The data in Kerry's report is occupational therapists employed by the council rather than employed by the trust. I'm happy to get the data on the number of occupational therapists employed by the trust, and I will if I send it through to Kerry, then he can ensure it's distributed appropriately. But we definitely do have occupational therapists. They do assess patients as part of the discharge process. Clearly we would like more, but they definitely are there, and they do take part in the process. But I'll clarify the numbers for you and come back to you.
That's excellent. Thanks, Simon, and appreciate you taking that one forward. Right, so good discussion, folks, on the adult social care performance report. Kerry, I think there's some undertakings from you to provide further bits of information. I think we've had a good conversation about what we might do to enhance the content of the report next year in terms of some case studies to really bring the performance information alive. Grateful to everyone for contributions, and with that we'll move to the next item, if that's okay. So the next item is on direct payments uptake. Kerry, if you would be able to provide the panel with a short update on the direct payments project. I know this was established in late 2024 with the aim to increase the number of adults and carers opting to receive social care support via a direct payment. So I'll pass over to you for an update, and Roy, I'll bring you in at the appropriate juncture for your question as well.
Thank you, Chair. Colleagues will recall that direct payments are a central tenet of promoting choice and control for people who use adult social services. Direct payments provide an individual with an opportunity to have greater decision-making freedom and control about how their needs are met and how they promote their own independence in line with their personal and family wishes. In effect, a direct payment transfers the responsibility for procuring services from the council to the individual, and resources are passed from the council to the individual to have that direct interface with the market. Direct payments are an actual central tenet, I've said that again already, in terms of the development of our current strategy, which is connected communities and better lives. We believe that people who use direct payments are more likely to be engaged with their community, to remain independent, and to maintain that independence over many years through expressing their choice and control. The Council adopted a 4-year plan in 2022, which included direct reference to how we empower and support communities to have freedom and control over their lives. This led to the service developing a plan, as you say, Chair, which was implemented in 2024 to significantly increase the number of people in receipt of direct payments in the service. There's an increase in the number of direct payments users by the end of March 2026 to 600, an increase in the number of carers in receipt of direct payments to 150 by the end of March 2026, for us to review our existing processes, to develop a co-production group, to engage and support social workers in terms of their understanding and referrals for direct payments, for us to review our in-house provision. We provide the support and assessments internally for direct payments through a service called Ealing Direct, and for us to develop a direct payment social care market directory in line with our Connected Communities delivery plan. The report that's attached sets out our progress against all these areas with a more detailed breakdown of the project plan in the appendices. Councillor Newstub did mention to me as we came into the meeting, we've got a very good video that promotes direct payments. I think it's really good, and it's really
I sent it to Anne-Marie, actually. I don't know if Anne-Marie, if you can, if you're in your email, it might be nice to share with the, it's only a couple, it's not even, it's only 30 seconds.
I think it's only 30 seconds long, but maybe I should have mentioned. No, okay, that's beyond that, but we can share it within the minutes. It's a really accessible and easy to understand video that explains how direct payments are and what support they can provide. Just to give you some of the highlights, we've significantly increased the training within the social work teams to make the referrals for direct payments, and we've seen a significant increase in the number of referrals that are coming into the service that then can be turned into direct payments for our customer base. We have made progress. We've already achieved the target of the number of carers who are receiving a direct payment in year, which is really positive because we think that makes a significant difference to family carers in their roles in terms of supporting their loved ones. The progress that we're making within the service user and customer base of direct payments has been less impressive, but we're expecting to do more in the coming months, and I'm still confident that we will hit the target we think we'll be hitting 400 to 500 by the end of March 2026, but I am pushing very hard that we hit the 600 in line with our commitments. So again, lots of information here. Some of it's very technical in terms of the performance reporting, which I think was what was asked for by the meeting, but happy to take any questions. And as I say, any I can't answer, I will get back to you at the earliest opportunity.
So I'll invite Alan, then I've got Goulet, and then I've got Councillor Steed. Before I do, can I just say one of the things that we obviously looked at as part of our scrutiny work previously was the direct payment uptake. I also separately engaged with the direct payment user group from ERSCAG, and one of the things that I noticed in the report, which was really heartening to see following the scrutiny work, was the move to providing more support in from council staff in terms of that direct payment uptake. That was a direct challenge from the direct payment user group, so it was really good to see that feedback being acted upon. Obviously, we appreciate there's still a way to go in terms of numbers, but I just wanted to provide that context because I think it's a real life example of scrutiny and kind of ERSCAG and the direct payment user group actually having an influence and making a difference, and us as a council responding to that. So Alan, over to you.
Thank you, Chair. When I first read this report, I thought, great, fantastic, things are improving. You're trying to do 600 in a year. Then I suddenly realised that actually what you were saying was you're trying to double what the current level is. And that's where I started to get very disappointed, because I can remember 15, 16 years ago when direct payments first came in, this was the way that everybody wanted to go. And then I started to look further at this report and to look at other information that was available. And I then became very disappointed in the uptake in Ealing, which over the 23-24 period was, I think, 99.7% of those eligible. And then I looked at the top scorer in London at 50%. So what are they doing that currently we're not doing? Could we learn from them going forward?
It's interesting because I think a very similar question came up at the last scrutiny discussion. Councillor Newstub.
Thank you, Alan. I couldn't agree with you more. This is probably the main of all the things I give Kerry a hard time about. For me, this is the most fundamental thing that we need to crack. Our rates are appalling. And I feel very strongly that this is fundamentally a moral and ethical issue. I think we don't have more people on direct payments. We're basically buying in to accepting that institutional versions of how people should live their lives are acceptable. I think direct payments are the way. I mean, it's a terrible name for something. I mean, let's rename them for a start. I mean, I really fundamentally think that this is about people just being treated with the same dignity and choices that the rest of us take for granted. And I think more widely as a system, and I can't speak to Ealing specifically, or I will talk to Ealing specifically, it's hugely incumbent on us to do everything to push this. And in all honesty, I don't think we've done the work early enough, and I think we should be more ambitious. And and as Councillor Conti said, all being willing around election cycles, it's certainly something we will be driving a lot harder. I really think that there are there's a wonderful organisation called TLAP, who I'm sure you'll be aware of, and there's a guy there called Clinton Farquharson, and he does this great skit on the way that we talk about care and the way that we talk about people accessing just the normal stuff they need to do to live their lives, to go to work, to be in their community, to do whatever they want to do is extraordinary, and it feeds into the language that we use. And I think the way that we our rates in Ealing kind of embody that. He talks about, when's the last time any of us phoned up our friends and asked what day services we were going to on a Saturday. I think there is an institutionalized kind of aspect to risk and not driving this forward enough. And it is absolutely, I'm going to push Kerry and the team as hard as we can, and any help we can have as a system, or as in terms of scrutiny and that kind of accountability, Alan, is frankly extremely useful. And I think we need to understand better why we don't do this. We can put everything in place that means we've got the project right, we've got the processes right, we've got the funding, we've got the training, but why is it that our social workers aren't able to make that option available to people or aren't making sure that it is understood and people are helped through that process? So I think a lot of questions that we need to be asking, and I'm hoping we will change the dial very soon.
Just on that specific point around the language and of direct payments, is there any reason that we can't think about that in the context of Ealing? Obviously, legally they are referred to as direct payments, but is the practice in other councils? Because it is misleading, isn't it?
It is misleading because people associate it with everything from direct debits to some financial transaction. It is the term that's used on a national level, and all the bodies will refer to it as direct payments, but there's no reason we can't change that to make it more accessible to local people. I'm not pushing back on the challenge. I think the challenge is absolutely right, and I think the aspirations that we're setting for local people and local communities is absolutely the right one. The training and the support to the social work staff and the additional capacity in the team is what increases the number of referrals and the capacity to move people into direct payments. When you speak to people on the ground and say, why aren't more people having direct payments? One of the responses is we've got a very good and responsive domiciliary care market. And some people would just rather the council provide the service from a good quality domiciliary care market rather than take on the responsibilities. I know that's not the answer, but this is what we're hearing, because we do have a strong domiciliary care market in Ealing. It's very flexible, it's very reflective of the communities we serve. It speaks all the community languages that we have in Ealing, which is really strong. And that's not the reason why we haven't done it, but that's maybe one of the reasons that people don't want to take up direct payments.
I think that's fair analysis and right that you put that forward. So Alan, you're happy? Yeah.
No, you've actually answered the question.
Oh,
I was going to ask you about language, so that's
Great.
fine. Thank you.
Goulet, I'm coming to you. Then I've got Councillor Steed. Then I've got Councillor Baines. Then I've got Councillor Conti.
Thank you very much, Carrie. And I can confirm, like as a carer of complex need patient, if direct payments had approached to me before the council arranged the providers, I would have considered it. But at the moment, like one of my questions is here is what is being done to ensure that carers who opt for direct payments are not burdened by the bureaucracy or risk, particularly in light of the independent reviews concerned about safeguarding fraud and administrative complexity. The reason I'm asking this is because in the last 10 years, I've been through 8 care providers through the council, and it's extremely difficult, and there's so much bureaucracy involved with that, and that's why I just didn't want to consider direct payments. When the team did approach me and we did sit and discussed it for an hour. My second question is, given that carers are providing more hours of care than ever before, how is direct payments program adapting to support carers with complex and fluctuating needs, especially those providing more than 50+ hours per week? And how is the direct payments uptake strategy ensuring that unpaid carers, especially those from underrepresented groups, are being proactively identified and supported to access direct payments, given that only 6.3% of carers currently access services and uptake among adult carers remains below target? Thank you.
Thank you, Goulet. It's a really interesting point, isn't it, that direct payments do, or personal budgets, or whatever we're going to call them, give people choice and control, but some people aren't in the place to want to have that additional administrative burden, as you describe it. The additional capacity that we're putting into the Ealing First team is to support the carers, the customers who are using direct payments, and we work with partners in terms of payroll, insurance, etc. So there's additional capacity to go into that space. Some people just need the support, and we're trying to create the capacity there to provide it. Really interesting points with regard to how we reach carers. Obviously, the council commissions with the carer centre to provide support to carers, with having a look in terms of that contract and making sure we're getting sufficient reach into the wider community in terms of the carers groups. Unpaid carers are encouraged to come to the council to get carers assessments, and we can offer support through that route. The more information have, the more support we can provide to people. The ongoing commitment to investing into the direct payments grants that we're paying to carers at the moment, it's not a huge amount of money, it's not going to change people's lives, but if it makes people's lives somewhat easier, then that's really important, and we're continuing to be committed to providing funding for that. I think that the carers group is going to be important in terms of the development of the direct payments offer, in terms of the areas that you've raised. So we'll continue to work and engage with you on that.
Thanks, Councillor Steed.
I have no wish to sort of join the pile on Kerry. All Alan and Goulet have already articulated the core points, I guess, haven't they? All I was going to say is I remember going with you and the previous chair of the committee, the panel rather, to Brent, which seems a long time ago actually, but I don't think it's quite that long ago, in fact. And I can't remember what the takeaways from those, because Brent was certainly at the time was doing pretty well comparatively. Yeah, Kerry, there's not much more I can say really, is there? But because it's all been said, but clearly it's an ongoing issue. Thank you.
And I guess just connected to that and building on Councillor Steed's point, I think the other there are other pockets of good practice. Are you through the kind of DAS network sharing ideas and strategies?
Yes, certainly, and part of our strategy to develop this plan was that we spent, I think it was 8 months, a year, developing our space in terms of where we want to be, where we see the best use of council resources to sort of make this turnaround. That did take us 12 months, and then the implementation phase. This hasn't been quick, but it's been very thorough.
Thanks, Kerry. Councillor Baines, you're okay, are you? Yeah. Excellent. So, oh, go on, Kerry.
Wait, what do you mean you turn?
Sorry, so what my question was initially was people who are taking self-care, how are they being supported and safeguarding being maintained for people that?
I think we'll get a response from Kerry on that one.
I think the safeguarding point is a really important point. So the support is as per the discussions we've had with Goulet, Councillor Baines. I think the safeguarding point is the council will always retain statutory duties in terms of safeguarding. So if an individual's in receipt of a direct payment and they have any concerns about risk or threat to them from people in the community or people providing them care, we still are statutorily responsible. So we don't stop our safeguarding responsibilities as a council, as a social services department, as a community. I think it's just a really important point, because sometimes people think that a direct payment is just giving all our duties across to the individual. But thank you for raising that.
Thanks, Councillor Baines. Thanks, Kerry. Councillor Conti.
This is really a follow-up from when Alan's your conversation about the question he asked. It was out of the 342 people who are on direct payments, is there any specific sort of demographic groups that have signed up? Like, is there, or in a particular part of the borough, is there any sort of pattern in terms of people that have already opted to direct payments? And does that inform us maybe on the route that we can go down in terms of increasing the numbers?
Anything you can say on that, Kerry?
Yeah. Not in terms of demographics per se. We try to aim our targeted work on adults of working age, so people under the age of 65. We think that there's lots of opportunities with those cohorts. There are certain groups that we're doing more work around, so people with mental health needs have been significantly underrepresented in this space, and we're working on that specifically. In terms of the demographic ethnic makeup of the cohorts, it's very, very varied. So it does represent the wider community. There's no specific groups that are specifically represented in terms of the uptake, but from our customer base perspective, there are variations. The very elderly tend not to move into a direct payments model at the point when they come in contact with the services. With high numbers of people with learning disabilities relative to the customer base and their families, tend to have younger people and their families more interested in direct payments at point of contact, especially when they transition into adult social care.
Okay, yeah, excellent. Roy, come and take a seat at the table. We have been offering you one for a while, so
Sorry, hello.
The question on direct payments is something similar to what's been asked before, but I could perhaps put our perspective on this a little bit more in terms of why people don't take up direct payments. It's largely a digital exclusion question in a way, in the sense that that people do need a level of competence and a level of being able to recruit and be able to deal with employment issues and all sorts of financial issues. So the question that we've put on the agenda is to do with the support people receive when they're on direct payments from the I think it's called Ealing Direct now. And the question that comes up really is to their staffing level in this team, because when an independent report was commissioned a couple of years ago, and it's on the agenda, the independent report of Ealing Direct payment offer made a recommendation that Ealing Direct the team should have an increase of 7 posts. And that because they were very understaffed comparative to other boroughs across London. And we were disappointed really to learn that in the main report that it's apart from all the other improvements that there's going to be in terms of how social workers and others deal with people interested in direct payments, but that the actual Ealing Direct team, which actually takes over and helps people to make a success of their direct payment, that there's only 2 support planners yet to be recruited, and that's been agreed apparently, but they're not yet in post.
Harry, could you provide an update on that?
Yes, certainly. So thank you for the question, Roy. The capacity is really important within the service. So as you say, we're recruiting additional 2 support planners into the team. 2's not a lot, but 2's an additional investment within the service. We're also looking at how we can improve the productivity of the service by making it more efficient, using different routes for supporting people to make their payments for carers, direct payments, fast tracking financial assessments. This says through the digital portal, but that doesn't help with your question with regards to digital exclusion, but also through the use of AI when we're doing our assessments, so we're more productive in the team as a whole. I think it's a really interesting point, the digital exclusion point, with regards to how people manage what can be quite complex arrangements. You can have a council managed direct payment where the council manages the services and procures services on your behalf. It's not as much choice, it's not as much flexibility, but that is sort of a halfway house into how we promote choice and control for individuals. I'm not going to say that we're going to recruit more staff above that, what we've already agreed to do over and above, but our aim is to make the processes more effective and more efficient so that we can see more people and get more people through the process of onboarding them on direct payments. One of the biggest off-putting things is people waiting at the front before progressing to a direct payment because they're worried about how their needs are met, they're worried about the risks that they're carrying. So take the point fully on board, but we're looking at other ways of becoming more productive.
Thanks very much, Kerry. And I think Councillor Newster wanted to supplement that.
I'm not going to get into staffing issues because that's beyond my remit, but like all of these things have been overcome elsewhere, whether it's digital exclusion or whether it's the hesitancy or whether it's we don't have to reinvent the wheel, as it's a well-established way of people being able to control their own lives and access care. So I do urge us, I'd love it to be minuted, urge us to be learning where we can from those other boroughs and to be implementing those learnings at pace. Thank you.
Thanks for the question, Roy. And I think the recommendation stemming from this conversation is that we'll continue to look at best practice elsewhere. I'm afraid, Gule, we are timed out on this item, but very grateful to you, Kerry, Councillor Newster, Roy, as ever, grateful to Erskag for the questions. We note the progress in the report. You can expect us to be back on your back at this point next year, but you've got the benefit of Councillor Newstub's close scrutiny before then as well. Next meeting is the 27th of November, so not too far away. We'll have that follow-up conversation with NHS colleagues as their thinking emerges. So do reflect on the question that I posed earlier around how we'll continue to hold the partnership to account moving forward in that new world. And Polly.
I just wanted to add that the Northwest, slightly bizarrely, I became co-chair of the Northwest London ICP at the last meeting. So so do let me know. Obviously, it's an organisation that's going to disappear relatively soon. So, but do consider if there are, certainly as Scrutiny chair and through your JOSC route, but more widely, if there's anything I can bring to the attention of the partnership
That'd be
in the coming months.
really helpful. And thank you, Councillor Ty online as well. Thank you everyone in the room, and have a good evening.